Now we play a gradient game. We have this patient, George. He's now 83 years old. He has an elevation of his TAVI gradient, so he received a valve. He had aortic stenosis. He's truly, you can see, really bad image quality. He's hard to scan. He has atrial fibrillation, ventricular extrasystole, and we see also to a certain degree already that there is LVH present after aortic stenosis. And now we want to know, is there a relevant gradient of his TAVI or TAVR, transaortic valvular replacement, or is it another gradient or another problem? We focus on the 5-chamber view. You see the ventricle a bit better. You see here the TAVR. There is certainly most likely a hyperdynamic left ventricular function present, but be aware there's also ventricular extrasystole. And when you use color Doppler, you also see a lot of turbulent flow. So now we have to figure out, where is the gradient? Is the gradient simply the aortic valve? Is it a problem with the TAVR? Well, with this continuous wave Doppler signal, you do see that there are also not only one but several signals in this one measurement. So we have to really be careful to what we measure and how we define and differentiate those signals. There are actually 2 peaks. You have this first peak and this second peak. So the first one, that belongs to the TAVR. It's overall in the mean measurement below 4 meters per second. So most likely it's not a relevant stenosis. But the second signal, that's still unclear. This is more this dagger-shaped signal. Here you can see it again. And this points towards an obstruction, interventricular or LVOT obstruction. And when you even optimize the image, you see here again the TAVR gradient and here this second flow. How can you solve this? How can you find where the gradient actually is? Well, you use the pulsed wave Doppler. You put the pulsed wave Doppler first in the aortic valve, then retract it towards the LVOT. And in the LVOT, we have this normal LVOT signal. It only needs one signal to be sure this is not significantly above 1 meter per second. So here is not a relevant gradient. You go more apical and you see that here still is no relevant gradient. But when you go even a little bit more inside the ventricle, so the mid-ventricular area over here, you see suddenly there is this steep curve, this dagger-shaped signal. So this is a case of mid-ventricular obstruction. And it becomes even clearer when you use contrast imaging. So there's a little bit of a bundle branch block, so the heart is not contracting entirely normal. So not all walls of the heart are contracting at the same time. So you see a little bit of this rocking motion. You see here again the continuous wave Doppler where you see this gradient again. And in this 2-chamber view, you even see clearer this mid-ventricular obstruction due to hypovolemia. It was summer, the patient did not drink a lot of water. So a case of hypovolemia. And the gradient is in the area of the mid-ventricle, so not in the LVOT. Here we have the second gradient game. We are discussing now a patient with TakoTsubo cardiomyopathy. You see this large apical ballooning, severely reduced function, but this hyperdynamic basal segments which you can see in this TakoTsubo cardiomyopathy. And you have, of course, the diagnosis of a HFrEF, so there are relevant wall motion abnormalities, large areas, so the function overall is reduced. The basal segments, they have to cover, so to speak, for the akinetic segment, so they are hyperdynamic, and you see that there is also most likely LVOT obstruction. Now we're interested about the gradients. This patient was also on our intensive care unit. And when we place a continuous wave Doppler, we do see a gradient in the LVOT. And now you again have 2 signals you have to differentiate. You have here the first, that will be the aortic valve, but then there's this second signal. It's also dagger-shaped, but it's not that steep at the end. So this points that this is a signal truly in the LVOT. Of course, you can use pulsed wave Doppler to see that there is no obstruction in the apex, but that is rather obvious as there are large wall motion abnormalities over here. So this is truly a LVOT obstruction. You can see it with color Doppler that there are 2 areas where there's turbulent flow. First of all, of course, in the LVOT, you see it over here, and also this area where there's mitral regurgitation present. So because of the SAM, the LVOT obstruction, the anterior mitral valve leaflet is pulled more and more towards the interventricular septum and thus creating mitral regurgitation. The more SAM, the more MR, and this is a vicious circle if you use catecholamines, which will even make the LVOT obstruction worse, and the patient will deteriorate and eventually even die. So what do you need to do? Well, the IVC in this case also did fit to a more hypovolemic state. It was collapsing. There were no B lines. And of course, with this large akinetic areas, with this severely reduced left ventricular function, you have to be very careful with volume administration. A personal tip from my point of view, scan the lungs. If you see more and more B lines, this patient has way more than enough fluid therapy, and this patient then is starting to have pulmonary congestion and eventually pulmonary edema. If you do not see any B lines, more volume administration will be possible. Furthermore, you can of course evaluate the gradient from time to time to see if it's more severe or if there's less gradient and also less MR present. Here I have this measurement of another gradient. So this is not an aortic valve or an LVOT gradient. You always have to be careful when you measure here. You see that there is not the aortic valve you primarily measure, but this is the measurement of mitral regurgitation. So always keep in mind where you measure and which gradient fits the actual structures you are measuring and visualizing.